Hi, my name is Marion Bornhorst, and today's date is 10/21/19. And today I'll be discussing case connections for Unit 4 and University of New England. And I'm going to be discussing cases 1 and then case 2. So let's start on discussing case 1. So case 1 presents us with a newborn whose condition after birth presented normal, but now she's on the decline. So she's developed lethargy, hypothermia, and apnea over the past 24 hours, and the physician suspects a metabolic disorder and then orders labs. So the first question deals with the types of labs that would be best to distinguish between a urea cycle disorder and a disorder in beta oxidation. So the options include blood glucose, urinary acids, serum fatty acids, and plasma glutamine. So when deciding which labs are best, it's important to remember what each metabolic process does in the body. So the urea cycle, in its simplest form, is the metabolic process to excrete ammonia from the body as urine. And this process relates to nucleotide metabolism, because as nucleotides are degraded, they are broken down into their main components, which are phosphate, sugar, and nitrogen. And for the nitrogen to be disposed of, the urea cycle must occur. So the process of beta oxidation is a catabolic process in the tissues by which fatty acid molecules are broken down in the cytosol to generate acetyl-CoA, which in the liver during the fasted state produces ketone bodies. So the initial step of this process of beta oxidation takes free fatty acids and activates them to acyl-CoA, derivatives by the enzyme acyl-CoA synthetase. And with a deficiency in beta oxidation, free fatty acid levels would rise due to the inability to process them through beta oxidation. And with that being said, it makes sense to choose this lab related to looking at serum fatty acid levels, but this doesn't really distinguish between beta oxidation and the urea cycle. So this wouldn't be a good test for distinguishing between them. Another choice that looks appealing based off of beta oxidation would be measuring blood glucose, and this would only have the ability to work if the individual is fasting, because beta oxidation is a fasted state metabolic process. And beta oxidation relates to blood glucose because this process produces acetyl-CoA, NADH, and FADH2. And acetyl-CoA is a substrate for ketogenesis, but also allosterically activates pyruvate carboxylase for gluconeogenesis, which allows for glucose release into the blood in the fasted state. In this scenario, you would expect lower than normal fasting levels of glucose in the blood during a deficiency in beta oxidation. However, glucose levels don't relate to the urea cycle as well as they do to beta oxidation. So overall, this measurement wouldn't really single out a beta oxidation deficiency versus a urea cycle deficiency. So instead, we're going to flip around and we're going to look more at the urea cycle. And a deficiency in the urea cycle would cause an increase in ammonia levels, as well as other precursors to the urea cycle, such as the amino acid glutamine. So looking at ammonia levels isn't part of the multiple choice, but we could also look further into the glutamine lab. So glutamine, like acetyl-CoA, derived from beta oxidation, can be used as a substrate for the TCA cycle during a fasted state when employing gluconeogenesis. Without sufficient acetyl-CoA in the fasted state, because of the deficiency in the beta oxidation process, glutamine would still be available. And with that being said, without proper beta oxidation, glutamine levels would decrease as it's being used more and more for gluconeogenesis in the absence of sufficient acetyl-CoA. And as stated previously, a deficiency in the urea cycle would cause an increase in glutamine as it's not broken down and disposed of effectively. So because glutamine levels would differ, elevating with your urea cycle deficiency and declining with beta oxidation deficiency, that is the best lab to choose out of the four. And the second question asks us that based on the patient's condition, decide which urea cycle enzyme is most likely deficient and which enzyme is most likely to be impaired, is least likely to be impaired. And the patient presents with elevated ammonia levels, elevated orotic acid levels, and normal citrulline levels. So the elevation of ammonia is not very significant. Elevated ammonia just overall means that there is, in fact, a urea cycle deficiency because we're less successfully able to dispose of the nitrogen that we have as waste. So the two keys to look at would be orotic acid levels and citrulline levels. So in terms of orotic acid, there are two metabolic processes that accept carbamyl phosphate on one of the urea cycle. Two processes that accept carbonyl phosphate. One is the urea cycle, and the other is the pyrimidine synthesis. An intermediate of pyrimidine synthesis pathway is orotic acid. So knowing this information makes it clear that in seeing elevated orotic acid, we know that there is too much carbonyl phosphate being produced as a substrate for the urea cycle, which causes it to enter into the second pathway as well. And the second indicator, citrulline, in short, is an intermediate of the urea cycle. And so knowing all this, I've decided that the most likely deficient enzyme is ornithine carbamyl transferase because it's unable to convert all of the carbonyl phosphate into citrulline quick enough. And the least likely deficient enzyme is carbamyl phosphate synthetase 1 because we are producing more than enough carbonyl phosphate. And then in turn it's producing more orthotic acid through the second pathway that I mentioned, other than the urea cycle. So the second case that I wanted to present was case 2, and this case describes a 4-day-old infant who is diagnosed with phenylketonuria after having demonstrated phenylalanine level of 6.6 milligrams per deciliter, which the normal range is between 1 and 2, so that's very high for an infant. And the first question asks that as a consequence of this presentation, which amino acid would become essential? So it's important to understand the condition of phenylketonuria, which I'm going to say PKU. And this is a rare genetic condition that causes the amino acid phenylalanine to build up in the body. And in this specific metabolic process of aromatic amino acids, phenylalanine is converted into tyrosine by the enzyme phenylalanine hydroxylase. And tyrosine is needed to create neurotransmitters such as epinephrine, norepinephrine, and dopamine. So with PKU, with this condition, there is a defect in the gene that transcribes for the enzyme phenylalanine hydroxylase. And without this enzyme or proper levels of it, the conversion of phenylalanine to tyrosine is inhibited. And this makes tyrosine an essential amino acid because tyrosine isn't being produced through this process. It needs to be consumed at proper levels in the diet. For this individual, the PHE dietary restriction therapy was useful in reducing plasma phenylalanine levels. And then the prompt asks, what are the potential causes of the presentation of PKU? And I already discussed one of the potential causes, which is a defect in the gene that transcribes for the enzyme that converts phenylalanine to tyrosine. And in turn, this would elevate phenylalanine levels in the body. And for this to occur, both parents of an infant need to pass on the defective version of the gene in order for them to inherit the disorder. And another cause could be potential lack of the cofactor BH4. And this cofactor is necessary when looking at phenylalanine hydroxylase because it's necessary for that enzyme and the conversion of phenylalanine to tyrosine. And that could be another potential cause of the disorder. And the last portion of this case asks us to compare another infant to our first infant, so patient B versus patient A, by performing a BH4 load test. And this loading test administers a synthetic cofactor BH4 into the patients 30 minutes before a meal, and then takes levels of phenylalanine 4 hours and then 8 hours later in the blood. So this prompt asks us to summarize the results of the BH4 load test from the graph of patient A and patient B. And as we look at the graph, we're going to kind of compare what it shows us between patient A and patient B. So it shows us that before the load test, before we added synthetic BH4, the patients had very similar phenylalanine levels in their blood. And then 4 hours after, we had a little bit of a difference. Patient A had more of an elevated phenylalanine, patient B had more of a declined. And then 8 hours later, we saw a dramatic difference, dramatic exponential decrease in phenylalanine levels in patient B versus patient A, which their phenylalanine levels still were slightly increasing, while patient B's was exponentially decreased. So that shows us that with patient B, the BH4 loading worked well to decrease phenylalanine levels in the plasma, meaning that patient B's issue is more so an issue of having BH4 present for the enzyme to be useful, rather than an issue in the transcription of the enzyme itself. So phenylalanine hydroxylase was present, they just needed the cofactor. And this shows that patient B would respond really well to adding synthetic BH4 into their therapy because they are lacking it, whereas patient A has an issue with the transcription of the enzyme itself. So thank you so much. I hope you have a good rest of your day.